Welcome to the MDedge Daily News. I'm your host, Nick Andrews.
And I'm MDedge editor Mary Ellen Schneider. Today, predictors for worse outcomes are hard to come by in specific rheumatoid arthritis patients.
Also today, a look at psoriatic arthritis and type 2 diabetes risk.
And later, new hypertension guidelines in Europe endorse lower blood pressure targets.
But we begin today with a troubling relationship between pediatric hypertension and MRI changes. In a pilot study, Dr. Mark Land and his colleagues found evidence of impaired white matter integrity on MRI in a handful of hypertensive children that is similar to what is found in adults with cognitive impairment from hypertension. Dr. Land spoke with MDedge reporter Alex Otto at Joint Hypertension 2018 in Chicago.
Of course, your brain is made up of gray matter and white matter. And white matter are the neuronal tracks that connect the different one part of the brain to the other. And that's where many of the lesions of hypertension in advanced hypertensive brain disease is located. So there are things called white matter hyperintensities that you can see on MRI that are known to be due to hypertension that are associated with vascular dementia. And what we're looking for is not that, but for much more subtle changes in the white matter tracks that you wouldn't normally see on a clinical MRI. These are research MRIs, but you can pick up these differences. These would far precede anything we would see clinically such as white matter hyperintensities on an MRI you would get just in the hospital.
That was Dr. Land of Rochester University in New York discussing MRI changes and pediatric hypertension. You can watch the interview in its entirety by clicking the link in the podcast notes.
Disease flares are common for patients with rheumatoid arthritis who achieve low disease activity. However, they are difficult to predict and are undeniably associated with worse disease activity, quality of life, and progression. This is according to the analysis of a prospectively observed cohort published in the Journal of Rheumatology. The cohort contained 152 patients with 28 joint disease activity scores below 3.2 for at least 1 month apart. The researchers report that nearly 1/3 of patients with RA and low disease activity experienced a flare during the 12 months of follow-up. Patients who had a flare experienced significantly worse clinical outcomes than did patients in sustained remission. They also experienced worse functional outcomes and higher radiographic progression scores. For instance, patients who flared experienced more than a 3-fold greater risk for erosive progression. The researchers also report that serum biomarkers were modestly correlated with scores at the time of flare. Dr. Katie Beckman is a researcher in the academic rheumatology department at King's College in London. She says that it is possible that a flare event is not solely the result of direct synovial inflammation, and suggests that it may be driven by other pathways, like chronification of pain. She notes that it is possible that 2 distinct subtypes of flare might exist. The first could be an inflammatory flare that's predominantly driven by an increase in swollen joint count and erythrocyte sedimentation rate, while the second could be non-inflammatory, with elevated tender joint count as well as a high patient assessment score.
Patients with incident psoriatic arthritis are at a significantly increased risk of developing type 2 diabetes when compared with patients who have psoriasis alone, as well as with the general population. This is according to recent research published in Rheumatology. In the study, researchers randomly matched psoriatic arthritis cases to either the general population or to a cohort of patients with psoriasis, but no psoriatic arthritis or inflammatory arthritis. Patients were followed from match to the point where they either no longer met inclusion criteria or received a diagnosis of type 2 diabetes, cerebrovascular disease, ischemic heart disease, or peripheral vascular disease. The researchers report that patients in the psoriatic arthritis group experienced a statistically significant higher incidence of type 2 diabetes compared with both the general population as well as the psoriasis group. They also report that for other outcomes, cerebrovascular disease, ischemic heart disease, and peripheral vascular disease, were increased for patients in the psoriatic arthritis group compared to the general population. However, risks were not increased when comparing the psoriatic arthritis group with patients in the psoriasis group. Dr. Rachel Charlton is a researcher in the Department of Pharmacy and Pharmacology at the University of Bath in England. Dr. Charlton says that these findings support an existing proposal in clinical guidelines that it is important to treat inflammatory disease as well as to screen and treat traditional risk factors early in the disease in order to reduce cardiovascular risk in patients with psoriatic arthritis.
And finally today, the European Society of Cardiology joined other international cardiology groups in endorsing lower targets for blood pressure treatment in its revised hypertension guidelines. The guidelines were released in August during the Society's annual Congress in Munich. Dr. Giuseppe Mancia is co-chair of the European Writing Panel. Dr. Mancia spoke with MDedge reporter Mitch Solar regarding the new guidelines.
So if doctors go below 140, they don't have to think that they have failed. That's already a very important result. But if treatment is well tolerated, they should try to go lower, close to 130 and perhaps below 130. So this is one thing. The second thing to consider is that the higher the blood pressure reduction, the greater is the number of serious side effects, leading to treatment discontinuation. And this has been shown very clearly by meta-analysis. And treatment discontinuation is accompanied by very marked increase in cardiovascular risk. So this is a query, in a way, which you have to consider, particularly in real life. And the third thing is that the evidence of incremental benefit is not the same for all clinical subgroups.
You can catch Mitch breaking down this study and more in this week's edition of the MDedge CardioCast. And that concludes this edition of the MDedge Daily News. You can find links to these stories by clicking the link in the description. For MDedge, I'm Mary Ellen Schneider.
And I'm Nick Andrews. You can subscribe to the MDedge Daily News wherever podcasts are found.